Welcome back to the Philadelphia College of Osteopathic Medicine, Georgia Campus School of Pharmacy, ASHP-SSHP Clinical Skills Competition, Case Number 5, the ASHP 2012 National Case for Schizophrenia. Although the psychiatric diseases are not really prevalent in the ASHP competition, they are a major part of the community, and these types of cases shouldn't be taken lightly. Sorry guys, I know you heard it a million times if you've been following us since the beginning, but my name is Michael Cooley at the PCOM Georgia ASHP-SSHP Student Chapter President for the academic year of 2017-2018. I'm currently a P3 working with faculty and staff to provide you an example of a PCP or Pharmacist Care Plan for a psychiatric case. Going back to our legality, I would like to explicitly say my view doesn't reflect in any way the views of the faculty, staff, the school, and of ASHP. The school has no financial ties or disclosures, the information is not sponsored by ASHP, and for completeness sakes, the information is never to be used as medical advice or substitute for a medical professional. If you are having a life-threatening emergency, please call 911 or go to your nearest emergency room. Make a SOAP note however you like, but always remember that consistency is key. I always like to mention this because if you're new, developing your own style is paramount to your career, because now, after development, you have a foolproof method to work each case in an efficient manner. Again, here are the formal references provided at the national competition. Always refer back to your student handbook and your faculty advisor about which references will be provided at the local competition. Before we dive deeper into the PCP, have you made your own acronyms? If so, go ahead and leave them down in the comments below. We'd love to hear what you've made. Alright, taking a look at this objective, we see that he has an allergy to penicillin, no surgeries. In his past medical history, he has had schizophrenia for 12 years, and now he's presenting again with a psychotic episode, indicative that the disease is uncontrolled, although this occurred after his dose increase of his current medication. And currently, for his history of present illness, we can see that he presented to the emergency department, agitated and paranoid, assaulted the staff, and then required treatment of lorazepam and haloperidol. In the social history, the only thing that I do want to mention is his current smoking history. He is at 1 pack per day. For his vitals, in our intents and purposes, nothing's out of the ordinary. Physical exam, fatigue, insomnia, again correlated to the symptoms mentioned with the increased dose of the quetiapine. Mental status exam, we do have confirmation with acute exacerbation of schizophrenia. And in his labs, we should pay real close attention to his cholesterol, specifically his total and his LDL, which are elevated. We see a decreased level of potassium, not by much, but it is something that is to note, and an increased level of A1C onto the assessment and the prioritized list. For the number 1 problem, I have schizophrenia. For the number 2 problems are things that must be addressed in this visit. I included depression, hypokalemia, and the nicotine dependence. This is a very easy miss, as normally we combine the cessation or smoking cessation and the dependence into one category. And I'll talk more about that in the next slide. For follow-up, I have hyperglycemia, hypercholesteremia, obesity, only because they mentioned it as part of the past medical history, and obesity is part of the treatment options, and smoking cessation. Alright, going into the plan. This section is going to be just a little bit longer, so bear with me guys. Now most importantly, every section of your plan should include your Mr. T. And that's going to be your monitoring and therapeutic endpoints, your recommendations of therapy, and your therapeutic goals. Looking at our number 1 problem, we see schizophrenia. Now looking in your printed references, it's pretty self-explanatory which treatment guidelines you should use for this disease. Some important things I would like to note is, does the disease have any acute exacerbations? And in this case it does. The patient presented to the emergency department, agitated and paranoid, and assaulted the staff. Then we have to determine the types of symptoms the patient is presenting with, and in this case, according to references, they are positive symptoms of schizophrenia. As we're looking to treat the disease, we should definitely be conscientious about his weight, his hypercholesteremia, when we do the treatment options. When we do schizophrenia treatments, we always have to be on the lookout for EPS or extrapyramidal symptoms, especially shaking. The next is cardiovascular effects, mainly due to the hypokalemia. And with schizophrenia treatments, there's always a risk for adrenergic and cholinergic activity and inactivity. Definitely metabolic side effects, especially since his waist circumference is already massive and his BMI is already a problem. Next, looking into the depression, we see that CBT is mentioned both in depression and schizophrenia. CBT being cognitive behavioral therapy. If they are recommended, you should always put it in the recommendations of therapy, even if it may seem redundant, only because it's a different diagnosis that has a different treatment option. Next, looking into the nicotine dependence. According to faculty, because of the acute exacerbation of the schizophrenia, having a need for nicotine might actually decrease his agitation. In most cases, we would actually combine the smoking cessation and the nicotine dependence in a follow-up bullet point down in the third or number 3 problems. Alright, that concludes today's sessions. Thank you so much for attending. If you have any comments, questions, or concerns, please leave them in the comments section down below so that we can improve these sessions. Thank you.